Hey guys, Dr. Priya here. I know I promised you a short video on how you examine the cranial nerves. So here we go. It's just going to be a very quick overview of the cranial nerves and what they do, and a brief description of what you're going to do when you actually examine them and how that ties up to the function. Okay, so just as a quick reminder, you guys said you know the names, but there are 12 cranial nerves and these are their names. And this is a really short summary of the function of what they do, and we'll talk about those in a little bit more detail. And this is just a rhyme in the middle, a suggested one to help you remember the cranial nerves. Okay guys, it's just a quick reminder of the cranial nerves and where they are in the brain. You'll be doing this more in anatomy, but the key point I wanted you guys to actually see from this diagram is the fact that cranial nerves are bilateral. They come from the right and the left, and they go out from the various points of origin within the brain and the brainstem to actually go and innervate the various muscles of the face. So when you think of the cranial nerves, they are actually, for the motor component, they are the lower motor neurons. And from the origin in the brainstem nuclei, they will actually go out and innervate the muscles. So they are the cranial nerve equivalent of the lower motor neuron. The upper motor neuron is from the cortex in the cerebral cortex down to the brainstem nuclei. Okay, and that will become relevant in cranial nerve 7. Okay, guys, so just to tell you a little bit about cranial nerve 1. Cranial nerve 1 is the olfactory nerve, and olfactory means sense of smell. So if you look at this picture, you can see there's a rose which smells good, and there are chemicals from the rose that escape into the air. And when you inhale, they actually enter the nasal cavity, and they go up to this area in the upper portion of the nose, which actually contains olfactory neurons. So those smell molecules actually stimulate these portions of the olfactory neuron, and those molecules actually bind to this neuron and trigger off an action potential that will eventually go to the brain. So and you can see here, these are the olfactory receptor cells in the olfactory mucosa. They actually synapse in the olfactory bulb itself, which is inside your brain, and there's a right and a left, and that will actually then eventually go to the olfactory processing center within the brain. Okay, so because there are two of them, so you want to test one nostril at a time. And again, I mentioned smell is what you detect with cranial nerve 1. But the interesting thing about smell is what we mentioned when those molecules trigger the olfactory nerves. But there's also some substances that enter your nose that actually trigger pain receptors rather than smell receptors. And those would then be detected, innervated via cranial nerve 5. And those would include substances like ammonia and menthol. So since that's being detected by cranial nerve 5, they wouldn't be suitable to test cranial nerve 1. So usually for cranial nerve 1, people use substances like vanilla and coffee. Okay, cranial nerve 2 is the optic nerve. And if you can remember from the eye examination you did, when you look into the eye, you can see the optic nerve. And this white structure over here is the optic nerve. And that represents the portion where all the nerves from the retina actually coalesce here and then travel into the brain. And if you look here, what you can see is that if this is the eye from the back of the retina, that is the optic nerve, and that optic nerve will travel along its optic pathway to eventually reach the occipital cortex. And you will cover the details of this in your examination of the eye. All I wanted you to see is that the visual field will actually enter the pupil and go to the retina, and then it will travel via all the various pathways to actually reach the occipital cortex. But as you can imagine, if the optic nerve is actually this portion, after that it goes to the optic chiasm, and then it actually becomes the optic radiation. But if you injure the optic nerve here, you will cut off all the supply from one eye. So you have what's called well, you basically just have blindness over one eye. But if you actually have damage over the optic chiasm, then you will lose fibers that are coming from the nasal part of the retina on both sides, and that actually receive signals from the temporal visual field. So you have lost vision on both temporal and nasal fields. So by detecting where you lose your visual field, you can actually infer where there could be a lesion that's affecting your optic nerve. Okay, so since the optic nerve is responsible for capturing all this information from the environment, then it enters your retina, and then everything that is processed by your retina goes to the brain via the optic nerve. The main way you actually evaluate the integrity of your optic nerve 2 is by checking for visual acuity. And when you want to check for visual acuity, you do the Snellen chart. So you actually put your patient either 6 meters or 20 feet away from the chart, and you actually get the patient to read the chart until they reach a line where they can no longer read. Okay, and if you look at the chart, you can see that there are numbers to the lines, and each line will usually have a corresponding number at the side. So this is 20 over 200, 20 over 70, and what that means is that this 20 indicates the distance from the chart that you put the patient the 20 feet away. And this 200 indicates the distance at which somebody with what we define as normal eyesight could see that letter. So like this E, somebody with totally normal eyesight, what we define as normal, could read this E from 200 feet away. So if that's the only letter you can read at 20 feet away, your vision is that bad that it's at 20 feet away you can only read something that somebody could normally read from 200 feet away. So you call that 20 over 200. And that's how it works all the way down. This line 20 over 20 is what we define as perfect normal vision. If you can read anything better than that, then your eyes are even better than 20 over 20. Okay, so one thing about this is you have to evaluate one eye at a time. If you look at this picture, you can see the patient's actually covering one eye. So you always evaluate one eye at a time. And I just want to highlight that for cranial nerve 2, you are evaluating function of the optic nerve. You're not evaluating refractive function of the eye. So for this, you can actually let your patients keep the glasses on, as opposed to an eye examination where you are evaluating for all sorts of things, including a refractive error. And in that case, you can take the glasses off. Okay, so what else do you do for cranial nerve 2 besides visual acuity? Well, using an ophthalmoscope, you can directly see the optic nerve, what we saw just now, so you can see if there are lesions to it. You can also evaluate visual fields through direct confrontation, which you guys learned when you did eye examination. And but nowadays, actually most centers where they evaluate the eye will use a formal computerized visual field testing, which is much more accurate and can much more clearly delineate the visual field than confrontation testing. Okay, moving on to cranial nerve 3, the oculomotor nerve. The thing about cranial nerve 3 is it's got quite a lot of different components that it innervates. It innervates the extraocular muscles of the eye. In fact, it innervates almost all of them except two, the lateral rectus and the superior oblique. It carries autonomic fibers to the pupil, and those are the parasympathetic fibers. And it also innervates muscles to the upper eyelid, which actually elevate the eyelids. So what you can imagine is if you have a palsy of cranial nerve 3, all the extraocular muscles of the eye will be paralyzed except the lateral rectus and the superior oblique. Therefore, your pupil will move into a down and out position. You won't have the fibers which constrict the eye, which is what the parasympathetic does, and therefore the pupil will dilate, and you will have ptosis because you no longer have supply to the muscle that keeps it up. Okay, this is just reminding you of all the different innervation of the various muscles that move the eye. So what you can see is lateral rectus is supplied by cranial nerve 6, superior oblique is supplied by cranial nerve 4. Everything else, your superior rectus, inferior oblique, medial rectus, inferior rectus, are all supplied with cranial nerve 3. So if you paralyze cranial nerve 3, the only thing left is the lateral rectus, which pulls the eye laterally, and the superior oblique, which pulls the eye downwards and inwards. So if you only have those two left, it will deviate that way and it will go down and out. Okay, so we also mentioned that cranial nerve 3 supplies the fibers that actually supply the pupil to allow it to constrict. And I just want to kind of remind you guys of how this actually works in terms of responding to light. I think you all know that when you're in a dark room, your pupil will dilate, and when you're in a bright room, your pupil will constrict. And this is based on a response to the amount of light entering the eye. So if you think about how that pathway works, light enters the eye and it's actually carried into the brain via optic nerve, right? Cranial nerve 2. So as it enters the brain, some of those fibers go all the way back to the occipital cortex. But some of those fibers actually go into the brainstem and innervate a structure called the Edinger-Westphal nucleus. And what you can see here is that the information from one eye will actually innervate both Edinger-Westphal nuclei, And from the laryngomerisphere nuclei, you will have fibers that go via the parasympathetic fibers of cranial 3 to innervate the pupil. So if there is a lot of light and the pupil wants to constrict, it will then use this pathway and constrict the pupil. However, if you have damage to cranial nerve 3, then even though light from the optic nerve enters, you cannot relay that information to the pupil and the pupil cannot constrict. Therefore, you end up with a dilated pupil. Okay? This part of it is showing you another possible problem, and that can show you that pupillary defects don't only occur with damage to cranial nerve 3, but cranial nerve 2 as well. You can get something called an afferent pupillary defect, which is sometimes called a Marcus Gunn pupil. And in this, what you want to imagine is that your problem is now with the optic nerve. So even though you shine light into the eye, that information never reaches the brain. And therefore, your pupil is not able to react based on that incoming light, since you're not able to detect it since optic nerve is damaged. So what would you see if it is a unilateral optic nerve lesion? Well, what you're going to remember is that light shining in one eye, if it can be detected, would cause a pupillary reaction in both eyes. But if light cannot be detected in one particular optic nerve, then neither eye would dilate nor constrict. If it's light, then it would constrict. Okay, so what you want to imagine is that, okay, this is normal, there's no light shining. In somebody who has a normal functioning eye, the right eye is okay, you shine the light into the right eye and both eyes will constrict. But if you have damage to the left optic nerve, when you shine the light into the left eye, because the optic nerve is damaged, that light never reaches the brain and therefore signals never reach both eyes. So both pupils will remain dilated even though light is shining in the left eye. But when you do this swinging light test and you move from one to the other, when you shine in the right eye, both will constrict. When you shine it over the left eye, both eyes will begin to dilate. So that means when you swing it back to the right side, it will look like both pupils are constricting. So you get this kind of effect that is very odd, that when you shine light in one eye, actually you will see the pupil dilate. And then when you swing back to the other eye, you'll see it constricts. That's what you call the afferent pupillary defect. That actually indicates a lesion in cranial nerve 2. Okay, so cranial nerve 4 and cranial nerve 6, the trochlea and the abducens, both these nerves are pure motor and they only supply the muscles, the extraocular muscles of the eye. So they're pretty easy to understand. And again, the lateral rectus is innervated by cranial nerve 6, superior oblique by cranial nerve 4. So you just need to imagine that if that particular muscle is paralyzed, what would happen to the eye? Okay, we've talked about cranial nerve 3. You can have a look at this to make more sense of what happens. With a right fourth cranial nerve palsy, you can imagine that the right lateral rectus is paralyzed, so the eye cannot move towards the lateral side on the right eye. So if you actually, I'm pointing at cranial nerve 4, I'm so sorry. So if you look at cranial nerve 6, what's going to happen is that your right eye will always have this nasal squint. It will be like a convergent squint. It's always moving towards the nose because you no longer have the balance between the medial and lateral rectus. And you can move the eye to the midline when you are trying to look to one side, but that's the furthest you can go. You can't go all the way out because the lateral rectus is paralyzed. When you have the superior oblique, on the other hand, this movement is out. You can't move inwards and downwards, so you will have this this pattern seen in your eye movements when you do the head shape movement. Okay, so you do need to do that head shape movement as part of your evaluation, and depending on what abnormal pattern of eye movement you see, that will tell you whether or not you have a lesion, and you can make a very good guess as to which nerve is affected and in which eye. Okay, moving to cranial nerve 5. Cranial nerve 5 is a mix of sensory and motor, so you need to evaluate both portions of it. Let's look at the motor supply first. The cranial nerve 5 actually supplies the temporalis muscle as well as the masseter, or sometimes called the muscles of mastication. So when you want to evaluate these, you get your patient to clench their teeth and you put your hands over the temporalis and you put your hands over the masseter. And when the patient clenches the jaw, you can feel the temporalis and the masseter clench. And the other test you do is the jaw jerk, where you just have them open their mouth slightly, put your fingers here and tap. If there is an abnormal response, you get a brisk jerk or an absent jerk. It depends whether it's upper or lower motor. And then the sensory supply, you actually have three branches of the trigeminal nerve: the ophthalmic, the maxillary, and the mandibular, otherwise known as B1, B2, and B3. You will learn this more detailed structure and anatomy. I just wanted you to kind of see where all those nerves are coming from. And what you can see is that because there are three branches carrying sensory, providing sensory innervation to the face, when you clinically evaluate sensory lesions of the face, you need to touch over all three regions. So what you will do is to actually take a wisp of cotton and touch over the area supplied by B1, B2, and B3. This picture is not very accurate because the patient has their eyes open. You should actually get the patient to close their eyes so that their ability to actually say they feel something is not affected by visual input. Now this picture actually illustrates the corneal reflex, and the corneal reflex is where you touch the cornea with a really, really fine wisp of cotton. And if you feel that touch, because the eye is really sensitive, you will blink. Now the interesting thing about this is that the sensation, detecting the sensation, is cranial nerve 5. However, the blink is cranial nerve 7. So if you have a patient with a cranial nerve 5 lesion, they won't detect the sensation, nor will they blink. However, if it's a cranial nerve 7 lesion, they will tell you that they feel it, but you won't see the blink because that muscle isn't responsive. Okay, so this is cranial nerve 7. Cranial nerve 7 is the facial nerve, and as you can see from this picture, it innervates a lot of structures. It innervates many muscles of the face that we call the muscles of facial expression. On the sensory side, it innervates the anterior 2/3 of taste over the tongue, and it innervates your salivary glands, your sublingual and submandibular glands. The parotid is supplied by cranial nerve 9. And there is this muscle in the ear called the stapedius muscle that it supplies, but it's a very, very minor function, and you don't usually evaluate that on its own clinically. Now, these are all the expressions that you get the patient to do to evaluate your muscles of facial expression. Get the patient to look up and see if the forehead wrinkles. Get the patient to close their eyes really tightly, and while it's closed, you try to open it and see if they can keep it closed against resistance. Get them to smile and show their teeth, and you're looking for symmetry of the nasolabial fold. Get them to puff out their cheeks and try to put some resistance and see how weak or how strong the muscles of the cheeks are. Okay guys, so here is something that you're going to need to know, because in cranial nerve 7 it becomes really important to be able to differentiate between an upper and lower motor neuron palsy, because clinically it's very evident, because this is what you see. These are the muscles of facial expression. And if you have an upper motor neuron lesion, that usually means a stroke, so it's up in the cortex. If it's a lower motor neuron lesion, this is classically Bell's palsy, which affects cranial nerve 7 itself after it has exited from its cranial nerve nuclei. But what you actually want to notice is that the forehead receives bilateral innervation from both sides of the cortex, whereas the lower half of the face receives unilateral innervation. So what that means is that if you have a stroke and the lesion is up in the brain itself, then the fibers from the other side of the brain that is still normal will actually come down and innervate the nuclei that supply cranial nerve 7, and those fibers will still be able to supply both sides of the forehead. However, you will have this fiber that comes, the main supply, just like the rest of the body, is contralateral. So from the brain it goes to the contralateral side of the face and innervates this side of the face. But the other side of the face will no longer have supply because you had a stroke to this side of the brain. So this would have provided supply here, which would have also provided feedback to both, would have provided motor innervation to both sides of the forehead, but it would have supplied the motor innervation to this side, the lower side of the face. Since you now have a stroke, the wrinkling of the forehead is preserved because of the bilateral innervation of the forehead, but you've lost your ability to move the lower half of the face on the contralateral side. The difference when you have a lower motor neuron is that that lower motor neuron is carrying all the input from that particular nuclei. So if your lesion is in the lower motor neuron, even though there's bilateral innervation, all those fibers leaving it don't reach the side of the face, so you have total paralysis of half the face in Bell's palsy, whereas you have preservation of wrinkling of the forehead in an upper motor neuron lesion. Okay guys, cranial nerve 8, the vestibular cochlear nerve. This nerve actually innervates both structures in the middle ear, the fluid-containing structures in the middle ear. The vestibular component refers to innervation of the semicircular canals, and that is actually responsible for detecting the position of your head and neck in space. And you will learn the theory behind this in your balance lectures a little bit later in the semester. And the cochlear portion is what actually innervates and supplies hearing, which you will do in the lectures that talk about hearing. Okay, and in your active learning session on hearing. What I just want you to see is that both the vestibular portion and the cochlear portion are innervated by the vestibular cochlear nerve. So information about position of the head and neck, as well as all the incoming sound that you gather from the environment, both travel through cranial nerve 8 to reach the brainstem and then go up to the brain. However, in terms of clinical assessment, the component that you usually assess more for cranial nerve 8 is actually the hearing component. It's not so straightforward to evaluate the vestibular component in a GP setting. So when you evaluate hearing, if you remember what you learned in SEM 1, you start with the whisper test, where you just see if there's a problem with hearing at all, and then you move on to the tuning fork test, the Viney and Weber test, which help you differentiate between sensory neural hearing loss and conductive hearing loss. A conductive hearing loss would not affect cranial nerve 8, but a sensory neural hearing loss could affect cranial nerve 8, or it could be a problem with the cochlea, so you'd have to figure that out through further testing. If you do have vestibular disease, that will actually, usually you get a big clue in the patient's history, where they will usually tell you that they feel dizzy, and when you dig a little deeper, they'll tell you that the whole room is spinning around them, which is classical of vertigo, which is a hallmark symptom of cranial nerve 8 lesion on the vestibular side of it. Okay, we're going to move into cranial nerve 9 and cranial nerve 10, the glossopharyngeal and the vagus nerves. Now the things, these structures innervate an awful lot of things, but most of them you cannot actually evaluate in a clinical setting. You need to do this through inferring an awful lot of other things. So in a clinical setting, even though they innervate so many things, for both of them, all you do is assess the soft palate and the uvula. But if you look at cranial nerve 9, it actually is really important for carrying the input from your baroreceptors up to the brain. So if there was a lesion, it could affect your responses to changes in blood pressure and regulating your blood pressure. And it also innervates quite a lot of the muscles that innervate your pharynx, and it can have some impact on the production of your voice. However, from a clinical perspective, what we actually look at is the innervation that it carries to muscles that innervate the soft palate and some of the sensory supply as well. With cranial nerve 10, as you could hopefully remember, cranial nerve 10's main and very, very important function, it is that the main nerve that carries all the parasympathetic supply to all the organs in the thorax and in the abdomen. However, it also has some innervation of some of the muscles that innervate the soft palate, and that is what we're going to be looking at in terms of our clinical evaluation of cranial nerve 10. If you look at cranial nerve 9 and 10, oh, I'm sorry, the other thing I forgot to mention is that they both also innervate some degree of function of taste over the tongue, but it's a relatively minor contribution as compared to the cranial nerve 7, and cranial nerve 9 also innervates the parotid gland. But clinically, how do you assess both of them? Basically, you just look at the uvula, get the patient to say ah, and you could also do the gag reflex, where you gently touch your tongue depressor to the back of the throat and see if they can feel it. And when it comes to actually the abnormality you see in the soft palate and the uvula, on the side that is affected, there will be a lower level of the soft palate, because when they say ah, usually the soft palate rises up. But here one is up and one is down, and it will actually cause the uvula to deviate towards the normal side. Cranial nerve 11, or the accessory nerve, is a motor nerve, and that innervates the sternocleidomastoid as well as the trapezius. The sternocleidomastoid is responsible for the action of turning your head. The trapezius, one of the things it does is it helps you to shrug your shoulder. So clinically, you look for the ability to turn your head against resistance and to shrug your shoulders against resistance. It's very straightforward. Cranial nerve 12 is the motor supply to your tongue. So it doesn't have any sensory supply. So all you want to know is whether your tongue is normal. And all you need to get your patient to do is stick out the tongue. And if one side is paralyzed, the tongue will behave really funny. And based on the way it affects the muscles, when you have a lesion, the tongue will deviate towards the side where the lesion is. So it's pointing towards the left, and the lesion in your brain is on the left side. Okay, so that's a really quick, brief overview of all the cranial nerves, a core idea of their function, and how that links into what you're going to look at. So you're going to do more of this in the class, and you'll learn more of this in anatomy, and we will try to discuss this. If you have any questions about this, we can also work it through during the cranial nerves active learning session. So have fun, guys. Oh, right, sorry guys, just one last slide I wanted to show you. This one, you really don't need to memorize it, but I just found it and I thought it was a really nice summary. It shows you a summary of the various muscles that we evaluate clinically that are innervated by cranial nerves 5, 7, 9, 10, and 12. So if you look at this, it'll give you an idea of what they innervate and how that makes sense in terms of how we evaluate. Okay?